Welcome. I'm Donna Christensen. I'm a former member of Congress from the U.S. Virgin Islands, which is today preparing for a Category 5 storm. So if I seem a little distracted, that would be the reason why. But I want to thank the African Union and Ambassador Arikana Chihombori, who hopefully will join us later, for again being such a gracious host for this series. And it's really an honor for me to be able to co-moderate this roundtable with the distinguished retired naval officer, attorney, professor, expert on arms and nuclear proliferation, past coordinator of threat reduction and leader of the Global Health Security Agenda at the Department of State, now at the University of Pennsylvania and prolifically at Brookings Institute, Ambassador Bonnie Jenkins. And I'm also pleased to be here to participate in building upon the discussion that we had last year and the strategy that we developed at last year's Ron Brown series. We took the charges that you gave to us and Dr. Alan Herman's summary recommendations last year seriously. And the African Healthcare Infrastructure Committee has been very productive in the interim year. Among the achievements is the historic formal affiliation and MOU between Constituency for Africa and the Global Emerging Pathogens Treatment Consortium, GET Africa. Another important partnership that was enhanced since the last series is the one with the Global Health Catalyst at Harvard University, which addresses last year's recommendation to expand our focus to include non-communicable diseases. We are pleased that the director of the Catalyst, Dr. Ngwa, is here with us today, and that GET Africa's chief investigator, Professor Akin Abayomi, will be with us via video. One of the most important areas of focus as we left here last year was the creation of Africa's Center for Disease Control. And indeed, the center was officially launched in January of this year, witnessed by our own president and CEO, Mel Foote. And today, among the many distinguished speakers we will hear from today, we are honored that CDC's director, Dr. John Nkengasong, will be with us via video as well. One of the other recommendations summarized by Dr. Herman last year was that we needed to convince U.S. institutions that they should tap into into the skill set, the knowledge, the expertise, and the experience of the African diaspora. It is the focus of today's roundtable, and we look forward to the policy recommendations that we will develop together here today. Other recommendations that emerged from last year's dialogue included ensuring that the U.S. understands and treats the strengthening of Africa's healthcare infrastructure as a national security imperative, and that they should be encouraged to support the development and strengthening of African regional and sub-regional agreements. To me, that provides the perfect segue to my co-moderator. Please welcome Ambassador Bonnie Jenkins.
Thank you. I also want to thank the Constituency for Africa for hosting this event, and also for the AU as well for doing this. I think this is an important discussion regarding health in Africa. And I also want to recognize my colleague Mel Foote, who I've known for many years, who's been a strong leader of CFA. And I was just telling him last night that he's been doing this for a long time for CFA, and we really appreciate all his hard work. I'm not going to say a lot of introduction because I think a lot has already been said by my distinguished co-moderator in terms of where we are and some of the challenges that exist. But I think we can all agree that strengthening the capacity of Africa to deal with infectious disease issues and to strengthen global health issues is something that we all care about, and we all want to see ways in which that can be helped. I'm presuming that with the new CDC, that will also help to strengthen the capacity of countries in Africa to deal with health issues overall. So I think there's a lot that we can talk about that, and there's a lot of growing pains, I assume, that the CDC in Africa will go through, but we're very supportive of what they're doing. We're going to skip directly to our first opening remarks. Unfortunately, Her Excellency Chihombori is not here right now. She may show up, I'm not sure.
She'll be here in 15 minutes.
Okay, 15 minutes, so she'll be able to say a few words then. So why don't we go directly to our next speaker, Dr. Roscoe Moore Jr., who is the interim chairman of the Board of Directors for the Constituency for Africa and Assistant U.S. Surgeon General, retired.
Yes, thank you. I guess what I want to talk about is what healthcare is and is not. Healthcare is not a hospital per se. It's not treatment per se. It's not certain professionals that we can train to do treatment. It is a system. When you look at things as a system. So hospitals are part of that system. Physicians and other healthcare providers are a part of that system. But there are other people, hospital administrators, people who have to do sanitation, how you have clean water, how you have sewage, how you have disposal of infectious waste. It's a totality thing. So quite a few people think, well, if you have a hospital, then that solves your issues. If you have so many physicians, that solves the issue. It does not. So we have to look at a more holistic approach as to how we approach medicine, healthcare in this nation as well as other nations. One thing that I wanted to also say is that when we are criticizing other countries about their healthcare systems, what I like to do is first criticize our own country as to how we fall short. This kind of puts us in the same barrel, because we're not having people say, well, what we're doing is better. What we're doing is what we do. Whether it's better or not, it's another story. But it is functional. It does work. One could say, well, how well does it work? Well, if you look at their experience from Vietnam, for example, before Vietnam, if you had an auto accident in the mountains of Tennessee, you died. You bled to death. But because helicopters came in Vietnam, but people who were wounded in battle had to get them back, and that's what people are surviving now in Afghanistan and other places, because you have a mobile unit that was not developed on its own. It evolved. I talked about a second ago about the water issue. If you have a hospital or medical facility and you don't have clean water, it's an issue. I think a young lady was here early yesterday who talked about medical devices and those things, and people think, well, if you go, yes. Please say your name again. I'm sorry. Yes. She's talking about medical devices and those things. If you go in a hospital and you see a medical device, well, you may think, well, this is a modern hospital. But who repairs the equipment? Who disinfects the various instruments and those things? So it's a more holistic approach as to how one does this thing. And my experience has been, I've worked with the major agencies within Health and Human Services, with FDA and NIH, with CDC, and then later with the Secretary's Office. So I've run hospital systems in 40 African countries. And in my civilian life, I'm now with a publicly traded company that we actually buy medical facilities. So I do know a little bit about the medical care system and its problems and issues. And with that, I will stop, because what I want to do is just to set the landscape that we realize at CFA that everything is broader than what we're even presenting here today. So when people come and ask questions, well, why didn't you talk about this? Why didn't you talk about that? And we would say that if you want something to be talked about next year, that you contact us and let us know you would like certain thing to be discussed. and not necessarily to come here and tell us what we're not doing, because we know exactly what we're not doing. We're trying to focus on what we can do now and how we move forward. And the biggest thing is continuity. We're talking with Dr. Herman. Dr. Herman, just raise your hand a second, please. His report last year, he's going to do a report this year. What we tried to institute is to have institutional building so that one of these sessions goes to the next. It's a year apart, okay, fine. But we have had meetings between the years to see how we could, how far we've come and where can we go. So with that, I will stop and go on with the rest of the program. Thank you.
We're going to hear from Dr. John Nkengasong, the Director of Africa Centers for Disease Control and Prevention, via video. And just a brief word of introduction. Until recently, he served as a Deputy Principal Director of the Center for Global Health at the United States Centers for Disease Control and Prevention, CDC. Between 1993 and 95, he was the Chief of Virology and the WHO collaborating Center on HIV Diagnostics at the Department of Microbiology, Institute of Tropical Medicine in Antwerp, Belgium. He joined the US CDC in 1995 as Chief of the Virology Laboratory at the US CDC offices in Abidjan, Ivory Coast. He's the recipient of several awards, and most recently of the William Watson Medal of Excellence, the highest recognition awarded by CDC for his outstanding contributions and leadership in advancing the global laboratory services and programs to support the President's Emergency Plan for AIDS, PEPFAR. So if anytime that we're ready, let's hear from Dr. Nkengasong.
The Africa CDC was launched in January 2007 by the head of states and government of the 55 member states of Africa. And the mission of Africa CDC is to support member states to strengthen their capacity to be able to respond and control disease threats that are increasingly becoming an economic, a security, and a social threat to the continent. Africa CDC will rely on 5 pillars to start off its program. Firstly, it will strengthen member states to be able to develop strong surveillance and disease intelligence hubs. Second, it will support them to elaborate strategic plans for laboratories and networks. Thirdly, it will support them to develop innovative information systems in order to capture information and share them in a timely fashion to respond to disease threats. Fourthly, we work on developing pandemic preparedness and response plans amongst member countries. And lastly, to support the development of national public health institutes and research. The operation model that we use at the Africa CDC is simple. The headquarters, as some of you probably know, is located in Addis Ababa. And this headquarters will be supported by 5 regional collaborating centers, one located in Egypt, Nigeria, Gabon, Lusaka, Zambia, and Nairobi, Kenya. And these 5 centers, we hope, will be supported by the national public health institutes in each of the geographic regions. So that is a simple operation model. We hope to work very closely with WHO, the 2 WHO offices in the region, i.e. the WHO Afro in Brazzaville and the WHO office in Emro in Cairo, Egypt. We are hoping that with the disease threats that we're seeing on the continent, the increasing population, the changing climatic changes that we are seeing are all affecting the patterns of diseases. For instance, the population of the continent was about 300 million inhabitants around 1947. And as we speak today, the population of Africa is about 1.2 billion and projected to be 2.4 or 2.5 billion by the year 2050. This calls for new public health architectures that will help to drive public health and enhance our ability to respond quickly. As I said earlier, disease threats are becoming truly an economic threat and a national security threat to the continent, as we saw in West Africa during the Ebola outbreak. So we will focus on certain enablers. We would like to enhance workforce development for public health. We like to use innovative approaches to leapfrog public health practice on the continent. We like to work on the right partnerships. We're working with the right partnerships that will align with the agenda that the Africa CDC, in collaboration with WHO, will lay out for the continent, so that our efforts are better coordinated, better aligned, and we have a way to measure, have a metrics to measure the outputs there. So in all, we are looking for partnerships, and we call on you to join this effort in designing a modern 21st century public health agency on the continent. Thank you.
Our next presentation is from Professor Arikana Abayomi, who's a chief pathologist and head of the Division of Hematology at the University of Stellenbosch, South Africa. He is also the chief investigator for Get Africa, the global emerging treatment consortium, Get Africa. Dr. Abayomi is also the director of the NHLS Stellenbosch Cape Town Biobank. And so we're pleased to have him make his presentation today. And Jamisha Hoyle is our videographer here. And thank you, Jamisha, for helping us with these presentations and for NextGen's work and providing us with all of the webinars, including the one from Dr. Abayomi, which was really a really interesting webinar.
Good afternoon, everybody, and thank you for inviting me to participate in the Ronald H. Brown series for 2017, and I am particularly appreciative to Mr. Melvin Foot, the President and CEO of Constituency for Africa, in the theme of mobilizing the diaspora for the US-Africa agenda. I'm speaking during this session on healthcare infrastructure in Africa. And my name is Arikana Abayomi, and I'm speaking to you all the way from Cape Town in South Africa. So the theme and the focus of what I want to comment about is the situation of the gaps that we experience in biosecurity on the continent of Africa, and I'm going to relate these gaps to the recent major outbreak of Ebola that occurred in West Africa in 2014, 15, and 2016. So that, as you all know, was the largest outbreak that we experienced ever, with 28,000 people infected and 11,000 deaths and millions of people affected, and several countries were involved in this outbreak. So the main countries that were involved were Sierra Leone, Liberia, and Guinea, but it spread to Nigeria, Senegal, and Mali, and further afield to Europe and to the United States. And we're all aware of what transpired during that very trying period. So sometime in the middle of 2014, there was an index case that arrived in Lagos, and Lagos is a metropolis of 23 million people. And with an outbreak of a highly dangerous pathogen in such a crowded metropolis and megacity, a pathogen for which we have no vaccines, no treatment, and no infrastructure or human capacity to deal with, was a nightmare beyond our comprehension. So we were stuck in Lagos with increasing numbers of people getting infected by this viral hemorrhagic scenario. And we realized that every time there was a major crisis on the continent, that we relied heavily on international support from organizations like Médecins Sans Frontières, Red Cross, Red Crescent, Oxfam, and the likes. So we felt that we needed to put together an organization that would be in a position to help respective governments and organizations based in the continent of Africa respond to biosecurity threats. So we formed the Global Emerging Pathogens Treatment Consortium, otherwise known as GET or GET Africa. And this was launched in August 2014 in Lagos. And it grew very quickly with indigenous expertise from all walks of life, medical, logistical, operational, legal, cultural, and in a very short time we were at least 200 to 300 people strong, trying to focus on how to address what seemed like an outbreak that was escalating out of control in many parts of West Africa. So we put several strategies together, and together with multiple international partners that came to the aid of the most affected countries. We worked insidiously and tirelessly in Sierra Leone and other countries to try to build indigenous capacity to withstand this kind of outbreak. As you all know, it took about 3 years for the outbreak to be brought under control, and it had brought to an economic standstill the economies of several countries along the west coast of Africa, and it affected the entire continent of Africa. So in the wake of the outbreak, we realized that we had some other issues that we needed to address. From the large infectious nature of this outbreak, there were thousands and thousands of Ebola-related samples, particularly in the 3 countries of Sierra Leone, Liberia, and Guinea. And in the aftermath of the outbreak, these samples were lying around in less than satisfactory biosecurity environments, and they could have been accessed either accidentally by medical staff, in which case they could have triggered a fresh outbreak, or if there was accidental discharge into the community, or they could have been more precariously accessed by non-state actors. As you know, we have several non-state actors operating on the continent of Africa. So this was a biosecurity threat of great importance and urgency and concern. So with the assistance and funding from several international partners, we were able to conceive a project which we called the Sample and Data Verification Project for Ebola. And over the course of about 12 months, we've been able to secure and contain all the samples in Sierra Leone that were related to the Ebola outbreak. There were in excess of about 150,000 samples that were lying in various laboratories across the country. So they're now safe and secure in temporary facilities, and we're in the process of working towards the construction of a permanent repository and biocontainment facility in Sierra Leone, which is donated by the Global Partnership Program, where the samples will eventually be housed under maximum security and safe for peaceful research and protected from access by unwanted entities. So we are also involved, the GET Africa is involved with organizing an annual conference in Africa. It's called the African Conference on Emerging Infectious Diseases and Biosecurity. And we just concluded our 3rd conference in Accra, Ghana, about 2 weeks ago. And it was a very successful meeting, and we were appreciative of the involvement of the Constituency for Africa and several of your representatives that were present at this conference and participated in a very important way. So the main problem in Africa is a shortage of manpower, a shortage of infrastructure, a shortage of governance and legislative mechanisms that are important for managing dangerous outbreaks. So we're involved with assisting countries develop capacity, develop infrastructure, and very importantly, developing the necessary policies and frameworks that are so critical when you're dealing with a dangerous pathogen outbreak that's threatening to cause a public health crisis. So many of these projects are active and ongoing, and we are very dependent on relationships and partnerships with key entities, regional health authorities, regional governance structures, the WHO, the CDC. We're very excited about the creation of the Africa CDC and its regional headquarters. And we are very excited about the future collaborations with CDC Africa. And we look to CDC Africa and WHO to provide the leadership and the policies and the directives. And then we are available to implement many of these necessary issues, which are the capacity, infrastructure, and governance on ground where they're most needed. We're getting into partnership with many important organizations, and to mention the Constituency for Africa, we've recently signed an MOU with you, and we're very excited to take this MOU forward, and this is the beginning of the relationship. We started already in Accra, where you were involved in our conference in Ghana, and I'm participating now in this Ronald H. Brown series, and we hope that every year will grow from strength to strength, and our relationship will mature to realize concrete objectives on the ground. So I'm looking forward to a future of collaboration with the CFA, and I wish you all a very productive and fruitful conference in Washington. And I'm sorry that I cannot be with you on this occasion, but I'm sure that in the future we will have numerous opportunities to get together and work hand in hand to develop the necessary health infrastructure in Africa that is required for us to become resilient against major outbreaks of infectious nature that are able to destabilize countries very quickly and create biosecurity threats. Have a pleasant conference, and I wish you all the best in your deliberations. Thank you very much. Good day.
So you've heard from the chief investigator of the Global Emerging Pathogens Treatment Consortium, Get Africa, and from the director of Centers for Disease Control Africa, two of the agencies that, under the leadership of our president and CEO, Mel Foote, we have been very much involved in since we met last year. And now we're going to really get down to brass tacks, as we say here. We're going to have an update on CFA's African Healthcare Infrastructure Committee. And to lead us in that discussion, we have Harriet Shangarai, who is the coordinator of CFA's Africa Healthcare Infrastructure Committee. She's also the former chair of the Montgomery County, Maryland Committee on African Affairs, which serves as a liaison between African communities and the county government. She also works as a senior nurse case manager at the African American Health Program, which focuses on reducing health disparities in people of African descent living in Montgomery County. She's a native of Tanzania with a passion for community health. Her recent activities include launching of the Mental Health Awareness Campaign to break the silence on mental illness and related challenges within the African immigrant communities and beyond. Also joining her in this presentation will be Dr. Alan Herman, an independent public health consultant, and of course, the founding dean of the National School of Public Health, Medical University of Southern Africa of the Republic of South Africa. Dr. Herman has extensive experience in developing and managing epidemiologic and public health research projects and is quite adept at secondary data analysis. In 1990, he helped develop the Baltimore Project on Infant Mortality Reduction. It's an initiative in Baltimore, Maryland. In 1990, he was member of the steering committee of a consortium of research programs for maternally-linked data from the National Institutes of Health, the Centers for Disease Control and Prevention, also included the University of Oxford, the Australian Institute of Child Health, the Israeli Central Bureau of Statistics, and the University of Bergen, Norway. He is the CMO of Cannabis Science and is the author of the brief, which is the foundation for this roundtable, and the African Healthcare Infrastructure Committee, which is entitled Strategies for Strengthening African Healthcare Infrastructure. So we'll start with Harriet.
Thank you. Good morning, everyone. Yes, I want to thank you all for coming. And I want to say, as a coordinator for the African healthcare infrastructure, it's amazing how we were brought together here as a result of Ebola epidemic. They said nothing else can bring you together as much as adversity. But we believe that what we share, the purpose behind it, and the vision is really what has allowed us to stay committed and true to this mission. Most of us here, as you heard, came here, wanted to do something and ready to go. We want to do something to intervene. But it's one thing when you respond to a crisis, and it's totally another when you have a plan in place. So our goal was to develop a proactive plan so that we stay on top, because crises are always going to be there. If it's not Ebola, it's something else. So we went out, reaching out for stakeholders all over around, not only in the US, but in the continent and diaspora. As Honorable mentioned earlier, we have many in the room from Harvard University, Get Africa. We came together to say it's not going to happen again. If it does, at least we know who is where, doing what, and how can we work together. After all of that we met again this year as a committee, not here in AU, but we always meet at least every 3 months. We noticed that the language changed. We were sitting there talking about, we like change. Change may be good, but not the changes that we had proposed by the US administration with the budget cut. That was scary to everyone. You all know that we're coming, or I'm coming, and many of you, the continent is depending on donor-funded programs significantly. And majority of the countries are not necessarily prioritizing the public health, or is not on top of the agenda. I know it has been a requirement for all those countries under the AU to put at least 15% of their budget towards their health care. But that was 2001. By 2012, it was only one country, that report from WHO. 2014, just a handful. If we're gonna do something, we gotta hold everyone accountable. All stakeholders coming to place and hold each other accountable. So pretty much the updates that I have for you is what we have done or what we are doing, but we need more commitment. We need more people to come together. And I'm gonna ask Dr. Herman to give us the update, and welcome to the African Affairs Infrastructure, and thank you very much for being here. Thank you.
Thank you, Harriet. I do apologize for not circulating the update to you before this meeting, but you will get it after this meeting. The Lancet Global Burden of Disease Group just published most of their data last Friday, and I've downloaded the data and done analyses for Africa very specifically. In September 2015, the United Nations moved from a Millennium Development Goal framework to a Sustainable Development Goal framework, and we can argue as to what a sustainable development looks like. But for health, which is Goal 3, there are 17 indicators and almost 48 sub-indicators. And I've analyzed the data, and I was sitting there and doing some new analyses next to Will, and he must have looked at me and wondered why I was still preparing my paper at such a late date. The interesting thing is that the Sustainable Development Index, which is a composite index of income, global, the development program indicators and levels of poverty, has steadily increased in Africa from about 0.25, and the maximum is 1. And a country like Finland has a Sustainable Development Index of 1. So Africa started at 0.25 in 1980, and is now around 0.4, with some countries having indices of 0.7. Countries like South Africa, countries like Rwanda. So this Sustainable Development Index has been rising steadily over the last 2 decades, which reflects improvements in the quality of life of many African countries. But countries like the Democratic Republic of the Congo still has a Sustainable Development Index of 0.1, which is 10% of what they have in Finland. I mean, it really is a country in trouble. And it's reflected in the health indicators. So when we take the Health Sustainable Development Goal and we look at how it has changed since 2000 to 2015, there's been a fairly steady rise in the Sustainable Development Goal for health. But it's still a very low Sustainable Development Goal. It's around about 0.4 at the moment. It sort of mimics very much the Sustainable Development Index. But this is the problem we face. Non-communicable diseases are on the rise. Neglected tropical diseases are on the rise. Tuberculosis is on the rise. Malaria is on the rise. We all think it's great that infant mortality and under 5 mortality have declined since 1960 across the continent, and life expectancy is now, after AIDS being managed more appropriately, life expectancy has gone up. But let me give you an index of the fragility of health. In Rwanda, before the great crisis, the life expectancy was around 72, one of the best countries in the continent. With the crisis, the life expectancy dropped to 28, and then rose again to being the best in Africa. So it's a fragile system for health in Africa, and any little issue, or sometimes a big issue, can change life expectancy. Ebola has had that effect. HIV has had that effect. So that's the status, and you will get an update on my report, hopefully in the next week or so. I've finished the analysis. I have to write it up now, so I will do that next. In summary, the global burden of disease has an interest in country-level data and in European and American data, and not a real interest in African data as an Africa-wide issue. And we at CFA, and those of us interested in African issues, and hopefully John and Kahasong and others that work on this, can create an Africa-centered data analytic framework that allows us to report very easily what's happening continent-wide and where the trouble spots are. So thank you very much.
So I'm going to turn this over to Ambassador Bonnie Jenkins to introduce our special guest ambassador.
Thank you. I think most of you already know Her Excellency here at the African Union. And once again, I want to thank you for allowing us to host this event here on behalf of CFA and for all the interest that you have. I know also in conversation yesterday with a number of the CFA board members, we were talking about the increased interaction that we've had with the AU and how much we really appreciate that interaction and how much we think it's going to make our work with you so much better, and also with the diaspora, because you have a strong interest in diaspora, so that we are very appreciative of that. So I just want to introduce Her Excellency Dr. Chihombori, who will say a few words.
Good morning, everyone. Once again, for some of you who were here yesterday, welcome back to the Africa House. I'd like to just start by hoping that everyone is well at home in the Virgin Islands, my sister. And then another one is on another hurricane is coming.
Yes, a big one.
Yeah. Really sorry about that. Hope everybody does well.
Thanks.
My son lives in Orlando, so they had to come home to Tennessee, but thank God they went back yesterday. Their house was okay. And I also just want to make a comment. You all keep thanking the African Union for allowing you to be here. Can I just correct you by saying you are home? I think the problem was you were not coming home. And so that needs to stop. It needs to get better. This is Africa House for a reason. It is your home. This building needs to be utilized. This room must be utilized. I was telling my staff back there to say, we need to have problems with, it's booked. Every day. So my sister, no need to thank me, thank AU. No, this is your house. And besides, you are the AU. So let's get that clear. We are having an interesting discussion today. How many of you were here yesterday? Okay, so we have a few who were not here yesterday. So if you don't mind, it's so important to me that everybody understands the story of the African Union and who we are and why we're here. Because quite often most people don't quite understand who the African Union is and what role do they play and how do I fit into the picture of this AU situation. The first ever known union of any African states was in 1958. That was between Ghana, Guinea, and Mali. It was soon after the French colonial masters had started the process of liberating their colonies. Most of the Francophone countries chose to, they were given two choices. You either are independent with no attachments to France, or you are independent with some attachments to France. Two countries chose to be completely liberated. That was Guinea and Mali. The French, of course, were not very pleased about that decision, because they gave the two options, not really expecting any country to take the other option. So in their anger, they went in and took everything that they thought they had brought to Africa, particularly those two countries, including pouring sewage pipes, concrete in the sewage pipes, completely devastating the two economies. The newly appointed president of Ghana, Kwame Nkrumah, in his efforts to help these two economies, created the first ever non-union of any African states, which was Ghana, Guinea, and Mali. Following that lead, a few other states grouped in Morocco and a few others grouped in Ethiopia. By 1963, the Pan-African leaders of that time decided it was time for all of the African states to come together. 34 came together in that original meeting in 1963 when OAU, Organization of African Unity, was created. It was during that meeting that Kwame Nkrumah proclaimed Africa for the Africans, African Union now. He also proclaimed that you're not African because you're born in Africa, but rather you're African because Africa is born in you. We have lots of us who might claim to have been born in Africa, who might claim to be of African heritage, but their thinking is not African. Their actions are not African. Their behavior is not African. And according to Kwame Nkrumah, they may not have Africa born in them. That's not to say they cannot have Africa born in them. They just need to realize that Africa is yet to be born in them. The whole idea of Africans coming together and creating a union was based on our history. The history that when our colonial masters came to Africa, they set out to destroy everything that was African. They found amazing kingdoms with history and religions that were impeccable. People so strong-minded, strong-willed, that they felt that the only way to truly defeat and conquer the African was to make the African feel that everything that is African is no good and everything that's English is better. That process of colonizing the African started in the early 1800s when the white people started settling in the various parts of Africa. And by 1885, the colonial masters had gotten together with a master plan. The plan was to divide and chop up Africa into tiny little countries. Quite often, the boundaries were cutting through tribes of the same people. You take a country like DRC, it borders 9 countries. The creation of little remnants of countries like Rwanda, Burundi, Togo, economies that cannot sustain themselves on their own. It was all by design to destroy the African and turn Africa into a truly dominated continent. For that, I say to our colonial masters, job well done, for we continue to suffer to this day from the legacy of colonialism and the legacy of slavery. So the creation of the African Union is an attempt to regroup and recreate that which was destroyed. Let's make no mistake about that. Since 1963 up to today, the OAU was renamed AU in 2002, but the whole purpose is to say, Africa, children of Africa, you are one. And until you start speaking with one voice, until you start singing a melody in unison as children of one Africa, you shall forever remain a defeated and controlled continent. It has taken us a long time. It's a steep climb. Our leaders meet twice a year to discuss issues pivotal to the continent. As of now, we now have a yardstick, self-imposed, by the African leaders after consulting with the African citizens. That is called Agenda 2063. It's got 7 aspirations of the African people. There's now a peer review mechanism, which is a voluntary process where the leaders meet twice a year and give a report on their progress based on the 7 aspirations of the African people, Agenda 2063. I was privy to have been in a room when the leaders were presenting their progress report to President Kagame, who has now been tasked with the responsibility of the reform of the African Union. It was very refreshing to listen to each and every head of state get up and give themselves a failing grade. That was refreshing. And then following that, President Kagame chastised each and every one of them and demanded that they do better. And that the next 6-month report, he expects to hear and see progress in all the African countries. So we are not there yet, but we're moving in the right direction. I have a responsibility to share with you the progress that is going on. It has not been easy. I think you sit back, and some of us, and say, what's wrong with this picture that allows France, our colonial master of centuries, to continue to take out of Africa $500 billion every year? To continue to say all minerals discovered and yet to be discovered belong to France. All oil discovered and yet to be discovered in the Francophone countries belongs to France. And that the African countries get royalties ranging from 12 to 15%. What kind of system is that? But I take it a step further and say, what is wrong with us? Why do we sit back and watch our continent, our home, looted, and we do nothing about it? You know, when you look at other diaspora organizations, the Indians, the Jews, the Irish, the Chinese, the Mexicans, they are very organized. When it comes to issues pertaining to them, all other differences fall apart. They come together and work towards a common goal for their sheer survival. They understand that. But when you ask for the voices of the African diaspora, you need to go to the graveyard. They silence. We don't exist. And we wonder why people don't think we matter. We wonder why people don't think Africa matters. People don't think we are relevant. Well, why should we be relevant? We don't make ourselves relevant. We expect somebody to make us relevant. How do you expect your colonial master to make you relevant? We are like a football game. They come to Africa to play games. We get coups that are manufactured. We get riots that are manufactured. We are fighting other people's wars. They use us now to do their dirty work to us on our continent. But we're all intelligent people, particularly the diaspora. Very well informed, very educated. So the question is, what is wrong with Africa? What is wrong with us? I ask you all to take a mirror and have a nice, strong, personal conversation with that image in the mirror. Because if you want to know what is wrong with Africa, now you have it. Unless we, as individuals, introspect, is my thinking colonized? Are my actions colonized? Is my behavior colonized? When I sit on that boardroom table making decisions about Africa, is my thinking in the right place? You see, you can have a leader who's educated, but if their mind is still colonized, what you're gonna get is colonial thinking and colonial outcomes. Maybe you might want to begin to understand why we are where we are. It's ridiculous, guys. It makes no sense that Africa should be where Africa is. And do we really want to leave our continent to our children and grandchildren the way things are? We all need to go back home and apologize to our children. because we have not done right by them. We are leaving them a continent that's even worse than we got it. Honestly, is that really what we want? I would hope not. I would hope not. So the African Union is as good as we make it. I hear people say, well, the African Union should have. I say, hold it. Who is the African Union? As long as you continue to make that separation between the African Union and you're not there yet. Because you need to know every step that you make, you are the African Union. And how you make that step and what decisions you make and how you look, you are the African Union. So take a look at the image in the mirror, because that is what is wrong with the African Union. That is what is wrong with Africa. I'd like to take a moment and thank my brother Mel and all the staff for organizing this wonderful program and creating a platform that we as Black people, we as the diaspora, can look in the mirror, and I hope to God that we make a decision to make sure that Africa is born in us. It's going to take all of us working together to make this machinery work. The African Union recognizes that for true sustainable change to come to Africa is going to take the diaspora. Make no mistake about it. When Chairman Zuma appointed me, she said they wanted me to look from within. She's a diaspora herself. She's a medical doctor herself like me. She said, I needed a diaspora who understands. Because until we bring the diaspora in, diaspora are not just remittances. There's more to the diaspora than just monies we send home. And don't forget the other diaspora who were forcibly brought here. They all must come home. So she looked at me, her last words were, there you have it. You got the diaspora. Bring them home. I hope to God we can all work together and find our way home. Welcome to the Africa House.
Thank you, Her Excellency, for that very powerful call to action. I want to assure you that it's the mission of Constituency for Africa under our leader, Mel Foote, to have all of Africa's children sing with that one voice, to reignite the African spirit within us, and to wake our diaspora out of that graveyard and come back to life on behalf of the continent and all of its people. Thank you so much. And it's hard to move on from there, isn't it? Will, you're up. Our next speaker is Dr. Will Ngwa. Saying that right? He is the director of the Global Health Catalyst Program that I spoke about earlier at the Dana-Farber Harvard Cancer Center and professor of radiation oncology and faculty medical physicist at Harvard Medical School and the University of Massachusetts. He also holds an international guest professorship at the University of Heidelberg, Germany, is well published, having published a number of books, including From Dust to Snow, interesting follow-up, The African Dream, which chronicles the experience of Africans in North America and Europe, the good, the bad, and the ugly, as he says, and how the African diaspora can work together to give back to their sending continent. So I guess we're right in keeping with the ambassador's remarks. He is the co-founder of the African Renaissance Ambassador, a non-for-profit organization in Florida with major activities in Africa focused on empowering women, youth, and addressing health disparities. So we welcome you and invite you to bring your remarks.
Thank you very much, Donna. Good morning, everyone.
Good morning.
All right, so let me say that, one of the emerging themes so far has been about collaboration and, working together. And I want to say that, even as the acknowledged mayor, I think one of the things from the report from last time was that, they wanted to do partnerships. And so I direct the program at Harvard on the global health. And I'm very proud that, mayor and the leadership of the CFA were able to partner with us and show that example, this past April. And during that conference, it turns out that 13 members of the organizing committee actually recognized Merrill as a Harvard Global Health Catalyst Ambassador Award. They gave him an award. And that was to recognize the silent work that he's been doing in the background, bringing people together and starting collaborations. I'll give you an example of a collaboration that actually started because Merrill did, bring people together. So last time when I came here, I actually met with a diaspora, African diaspora industry leader, Mr. Raymond Dabney, who is sitting here. And because of that, we started a collaboration. They were able to provide up to $2 million in terms of funding. That's how the U.S. actually benefits from the diaspora, And we've started this really amazing collaboration that is being, looking at how we can actually change not only cancer care, but also close the pain divide in Africa. So that's a really, those are simple examples. I can go on and on about what Merrill has been doing. But, I'm actually here to talk a little bit about, understanding the growing burden of non-communicable disease in Africa. And as Alan pointed out with the Lancet Oncology report that came out, it turns out that, if you look at that, the good news is that Africa's lifetime expectancy has risen, right? So in the 1980s, people used to die at age 52, averagely. Nowadays, they die at age 62, right? So that's a big jump. But the not so good news is that as you then live longer, the burden of diseases has, we're at a point where now it's kind of, we call it epidemiology transition, where, you have more people now are beginning to live longer. So diseases like cardiovascular diseases, cancer, diabetes, even mental health issues, they begin to emerge more. Of the 8 million people who died in Africa in 2015, over 1/3 of those who died actually died because of cardiovascular disease and cancer. That is a silent epidemic that's going on that we don't really know about. We don't talk a lot about. When Ebola comes, obviously, that's a big deal, but we need to stop and actually think about how do we address the growing burden of non-communicable disease in Africa. And, working with policymakers is a very, very important part of it because, even countries developing national cancer control plans is a big step in the right direction. Even just saying, okay, yeah, we acknowledge that non-communicable disease is a problem. So at Harvard, looking at partnerships, one of the things that we've really been driving is obviously engaging the diaspora. So that's a key component of, this annual meeting that we have. And right now, we want to make a comprehensive approach, not just one thing to healthcare. So one of them is cancer care, right? So how do you enable more people to have access to care? Okay, you also want to talk about, the workforce development. We heard about the CDC director talked about that. Education and training has to come with it. Okay, you have to think about research. So actually, when I tell you those numbers about epidemiology, some of those estimates, those are real estimates that are not scientific. Like people just make gross estimates. They don't have the data, the research data to actually inform the policymakers. So the research has to be there, and obviously outreach. Outreach means you want to engage people like the industry, you want to engage people like the policymakers, tell them that this is what it is. You have to engage advocacy. So all of us, like the ambassador mentioned, coming together and actually saying, yeah, we have to take our healthcare into our own hands. We all can do something. You don't have to be a healthcare professional to do it. You don't have to have an MD or PhD or what any of those. You can be a big advocate. You know, one of the things I always state is that, you know, cancer, for example, out of the 2,000 languages in Africa, very few of them, many of them don't have a word for cancer. Okay? If you don't even have a word for cancer, you can even start addressing it, right? So it means that, you know, people die of cancer, they attribute it to something else. It's witchcraft or something like that, right? And until we can educate our people, and we the diaspora, actually people, when we go back home, people listen to us, right? They listen to us. So we have an opportunity to create this awareness, the same kind of level. We can actually learn lessons from the HIV/AIDS epidemic. You know, when Africans rose together and sensitized people, you know, that has had a major impact. You know, the PrEPFAR program that was here was because of the advocacy, people like Alan and all those people coming together and working, to kind of address that issue. So, okay, I'll just have two more things to say. One of them is to say that, you know, the growing burden of non-communicable diseases, one of it is because of the lifetime expectancy. The other one is that as people, you know, survive HIV/AIDS, things like cancer emerge. Cervical cancer is a direct, actually is caused by that. It's one of the, reasons for people having more and more cervical cancer. People are also living longer, adopting Western lifestyles, right? So now we like eating pizzas. That's cool. You know, if you eat pizza, if you go to Kigali and you buy a pizza slice, you know, people think you're cool, you're coming from America, but you don't realize that it actually it's not healthy for you, right? So they're adopting these Western lifestyles. The other thing is tobacco, you know, alcohol. Tobacco, for example, as they regulated more here in the United States, you know, that's becoming more a big issue. They're coming to Africa. And so, you know, we actually need to stand up and also say, we can't accept that, right? So our young people are getting affected. All right, so I'll just give one example of why the diaspora is coming together. One of them is in looking at, you know, actually when I came here the first time after the ambassador was appointed, she actually laid out some of the key things that she wants to see. And I was very excited about some of those things, you know. In terms of training, online education, you know, we actually have a very good partnership from the Harvard Summit, you know, with the African Organization for Research and Training in Cancer that's now training people online, you know, building that capacity. And they are looking for teachers, right? They're looking for teachers where, you know, any of you may have a skill, you know, you can actually sit down, geographic barriers. So that's the cool thing is ICTs, information and communication technologies, have shrunk the world so much that you can sit here now and actually have an impact, you know, back in Africa without having to go there. You know, Harriet, for example, has this blog that she's been educating cancer patients in communities in Tanzania, right? You know, so we can actually do something about it. So we've done that. And then in terms of cancer access to care, you know, we've actually mobilized hundreds of diaspora doctors who are now starting an e-care platform and, you know, to allow patients to actually have access to care anywhere from Africa, right? So you can type on it, you just pull your time. You know, you have 30 minutes a week, 1 hour a week, you know, you can be on call, essentially, during that time. And somebody who has access, who needs care, can log onto that platform and get access, you know. And so the last 4 minutes that I have, I'm going to illustrate I'm going to have one of a colleague or partner in this to talk about eCare for Africa. And eCare for Africa is actually a platform that allows, you know, patients from anywhere in Africa to have access to cancer care. Jerry, thank you.
Good morning, everyone. Thank you. Thank you, Dr. Ngwa, for this opportunity. I feel really humble to be amongst you, amongst all these experts. And the interesting thing is I'm not in the healthcare field. I'm a solution architect for Deloitte, and I'm founder of eCare for Africa. I joined this battle, if I can say, from IT point of view. It started about a year ago where Dr. Ngwa, which is also my brother, inspired me to say, Jerry, what can we do to connect people? What can we do? The work they do here in the U.S., how can we make it available for the African population? I'm born in Africa. Africa is home. And thank you, Ambassador, for waking me up from the grave, if I can say. Because there is a lot to do. There is a lot of technology here. Cloud, a lot of new technology we can use, we can leverage to help people in Africa. Those technology are already saving up tons of life in the US, in Europe, everywhere. What about Africa? So we started this new platform, this growing community, by working with Dr. Ngwa and the Harvard, the GHC Global Health Catalyst platforms. We have a growing community of cancer expert, virus expert are joining us. They're currently testing the platform. We are really happy to see the result and see the way it's going, it's growing. And we really believe that by next year, we will have powerful impact on the African continent by helping people to reach out very easily to cancer expert or any expert in the US and everywhere. So that's the way we can solve the problem you mentioned here of short gauge brain drain has been mentioned many times since I joined you. And we're gonna be able to address this problem. So we're really glad of the progress we are making. We are seeking more partnership, and we are open to discussion. I'm really glad to be here. And this platform has a really powerful impact in future in what we can do in Africa. I have a small presentation printed out. You can have more detail about me. I'll be hanging around the whole day with you. Thank you.
Before we go to question and answers, and I'm going to have to step out for a minute, I'm a consultant for Gilead, which is a sponsor and part of this round table. And I just want to say on behalf of Gilead, again, welcome and thank you for allowing us to participate. Across Africa, Gilead works with a number of local partners to help ensure that our medicines reach the people that need them. Our pioneering generic licensing agreements have played a central role in expanding access to high-quality, low-cost HIV treatment throughout Africa. The company recently established an office in South Africa to manage our partnerships in the region. Our grant-making priorities in the following therapeutic areas are where we focus: HIV and AIDS and viral hepatitis. Within these therapeutic areas, we provide support for a broad range of activities, including disease awareness, disease prevention, professional education, improving patient access to care, improving quality of care, increasing scientific capacity, and strengthening healthcare systems. So I wanted to just say that we were supposed to have a speaker here in the next session, but they're all over the world today and no one could be here. So I just wanted to say that on behalf of Gilead Sciences. And I'm going to turn the question and answer period for this panel over to my co-moderator and open it up for your questions and comments.
Thanks. First of all, I want to thank, again, all of the speakers who were able to be here with us today and provide some very useful and educational remarks. I know according to the schedule, we are supposed to start our next session at 10:45, so we started a little late. So maybe we can have about 15 minutes of questions and answers, and we'll see what it looks like, and then we'll go from there. I will need to get an update, of course, for the panelists for the second session to see where we are. But if anyone with a question or a comment, we have some time. So if you could raise your hand, use your microphone, and then it has to be red to, not green, but red, and that means it's on. And then, as I said, identify yourself and give us your question. And I saw a hand over here, and then a hand over there, so please.
Yes, good morning, and thank you very much. My name is Reverend Angelique Walker-Smith. I'm with Bread for the World. I do the Pan-African church engagement work relative to policy on hunger and poverty issues. I am just very encouraged by everything that's been said today, and I was here on yesterday, and I want to thank all the collaborators for this moment that we are sharing. Last night was the debut of the film on barbarism that was presented by CSIS, and I was honored to be there in the company around the debut of the film at the museum last night. And one of the countries that was really focused on this matter of attacks on humanitarian aid, and particularly healthcare workers, was South Sudan. Is deeply concerning, and I encourage all of you to view this film. It's very important to the time we're living. Syria and Yemen was also featured. I'm wondering what the experts that are here have to say about this renewed barbarism that is happening. The saga has been there, of course, early on, despite the Geneva Convention, but we know there is just drastic drama that is happening on the continent of Africa relative to these attacks on humanitarian aid workers, medical workers, and others. I'm interested to know what your responses would be relative to the continent of Africa, particularly as we think about South Sudan, we think about the DRC and other places where we know this is happening. I'm happy for the very important approaches around indigenous care. This is so important. But we also know this is a globalized concern. And this is why we're having these conversations. What would be your responses to how we together can begin to systematically address these kinds of attacks that are going on, that are hurting our people? Thank you.
Thank you. Could you say, how would the rest of us get to see that film? Where is it exactly?
Yes, so I'm happy to say that the director at the CSIS, the health director, is the brainchild behind all of this. As I said, it just debuted last night for a special audience, and it will be coming in increments this week over the different chapters that came up in one film last night. But yes, the health director at CSIS.
Okay, so could we go to the website? Is that where we would?
Yes, I can send the link on to whoever would like it.
Okay, great. Would anyone like to respond to the question? Yes, Her Excellency?
Deputy Chairperson of the African Union, Kwesi Kwete, was visiting the United States a couple of months ago, and we did a courtesy visit to the State Department. We were sitting on one end of the table, and the members of the State Department were sitting on the other side, and we were just discussing various issues, and one of the members of the State Department did ask Deputy Chair, so what is the African Union doing about the issues of tourism? And I was expecting the usual response, which would be dissecting different scenarios, the Horn of Africa, West Africa, Boko Haram, Lord Resistance Army. But to my surprise, the chairperson said, yeah, maybe you could tell us what you're going to do about it. He said, since you made your decision to address Libya in the manner that you did, you opened the floodgates. And now Libya is the gateway for ISIS into Africa. So maybe you could tell us what you intend to do about terrorism in Africa. I'm saying this to say, we need to look at the bigger picture. Quite often, we are being told or forced to fight for crumbs under the table. We lose ourselves into who is getting more of the crumbs under the table and not realize that where you need to be is up here. I'm using that as an example to say the issues in South Sudan are bigger than the workers that are being killed. It's a much bigger situation that we as Africans, we need to understand it. Terrorism is an issue in Sudan, in all of the Horn of Africa. We can't limit it to the United Nations workers who are getting killed. There are many more Africans that are getting killed, that are suffering from the problem in that region. So I'm simply saying this to say, let's not isolate it and focus on the UN workers. Let's focus on humanity, the lives that are being lost in that region, regardless of what they do, because all lives matter. And so let's not allow them to isolate a small category of people because people are dying every day, regardless of what they do. And we need to look at the root cause of why that is happening and not just focus on the few leaves in the tree that are falling off. And that's all I can say to that, to say it's a bigger problem that is not only affecting South Sudan, it's affecting the Horn of Africa, it's affecting West and North Africa, terrorism being at the bottom of it, but there are bigger issues that I won't go into at this point. I'm simply leaving it out there to say the problems are much bigger than the movie and the UN workers that are getting killed.
Yes, please.
Let me just respond in part to that. One of the, I think, most fascinating things that you raised yesterday is that in 1885, the Europeans balkanized Africa. They split it up into multiple quote-unquote countries. And when the AIDS epidemic came along in the early 90s, I remember going around to many leaders in AIDS research and care in the United States, and one of them said to me, I think maybe we should let this generation of Africans die. Actually said that. And I thought, well, maybe the onus is upon me to try and find a way to solve this problem. So I worked with Mel, with Dr. Moore, and with Mr. Dellums to create what has now become PEPFAR. And suddenly, Africans are living. One thing that's fascinating to me is this obsession that Americans have and Europeans have about characterizing Africans as barbarians or some lesser form of humanity, and never talking to us about issues and never working with us jointly to resolve issues. We are the other people. It is actually quite remarkable that I've been doing this work for almost 40 years, and I've been called the other person so often that if I don't watch out, I think of myself as the other person. But as I grow older, I have a sense of, leave me alone, I am the person. And so I think one of the solutions is for those people who made the movie to find South Sudanese people who have thought about this and bring them onto the team that finds solutions. Else, none of those solutions that come from someplace else will ever work.
I am from, can I ask? Okay, so I recognize. I just want to answer as a Sudanese. Okay? From Sudan. I'm not going to tell you how old I am, but since
35.
But since I'm a child, the only thing I know is Sudan, South Sudan and North Sudan are fighting. I saw a lot of people or women, my mother talk about her husband died in South Sudan, and I didn't know what South Sudan, what was going in South Sudan. And this is grow up. And then now we seeing a lot, it's not like South Sudan. This thing is, we seeing our young kids, 24, 20, and even 8 years old are dying in this war between South Sudan and North Sudan. And we are not doing anything about it. And the only thing then we say, okay, we divide Sudan. I don't think the right thing to do is divide Sudan. And then what we ended up are having more people dying, killing each other. So the thing is, as Ambassador said, is more deeper for going for long years, and people, young and old, are dying there. And we really need, instead of thinking about the crumbs, let us think deep about what is the problem and try to solve it. And it seems like nobody's really care about it.
Thank you. Could you identify
Sudanese perspective?
Yeah. Could you identify yourself, please, for the audience?
Yeah, my name is Salma Mohammed from Purdue University.
Thank you.
I said I'm from Sudan. That's all.
Recognize it first and then second, yes.
Yes, my name is Luana Kendley, and I'm with the CFA African Health Infrastructure Committee. One of the things I wanted to ask was, what are we doing, or do we have a program already initiated for emergency response for things like the hurricane Irma and now Maria, that's going to be devastating the islands in the Caribbean, and naturally after that we're going to have issues with diseases and healthcare issues. And I was wondering if anyone knows anything about whether or not we have any plans in effect for emergency response for medical care.
Thanks. When you say we, who are you referring to exactly?
People in the African diaspora. We are part of the Caribbean diaspora.
That goes to the core of what I was talking about.
Yes, ma'am.
Why are you looking for us when we don't exist?
Oh, well,
Thank you.
okay.
We don't exist. If we existed, that would be one phone call, and you would be there.
Okay.
But until we organized exactly what the question you're asking, it would have been a simple thing. $1 from every one of us. Done. But guess what? We are so colonized, we're waiting for some white men to come and save us.
It's true.
To give us money.
Yeah.
To deal with it. No. This is what Mel is talking about. Let's organize. It would have been a simple phone call from Harriet, a simple email from Harriet, and it's done. But until we can do that, we don't exist, we don't matter, and we are still waiting for the white savior.
Actually, there's a very practical solution
Yeah.
for emergency management. One of CFA's partners are the
Charles
Black
Sharp.
Emergency Management
Yes.
Association, led by Charles Sharp.
Charles Sharp. Yeah.
And they're doing an enormous amount of work bringing people to the table. But Charles will tell you that he doesn't have enough resources to do this work. And I've been having emails from Charles in his email blasts about every single one of these disasters. And the problem with the most recent disaster is that many of the islands have had complete breakdown of infrastructure, water, electricity, etc. So there's a need to actually assist in both the rebuilding and ensuring that the water infrastructure doesn't infect thousands of people. So Charles would be your contact person, and BEMA would be key.
I'm part of the BEMA. Well, one thing too that we can do is we are all taxpayers, and the U.S. Virgin Islands belongs to the United States in quotation marks, and we can call our government and ask them to take a visit there, like they're doing in Florida and like they did in Houston. All of us are, I'm assuming, voting and tax-paying representatives of this country. So that's an issue that we can do without without being considered someone asking a white man to do something for us, because we do pay, and we are citizens of the United States, and they are as well.
I had a comment on this, or is it a different question? Because I think some folks want to respond to this specific question. Do you have a comment on this question, or you have a separate one? Sam?
Sam Opako, psychiatrist. Alan referred to the global burden of disease and so on. I think people forget that the initial work for this study before Murray and Lopez actually came from Ghana. I say that to emphasize the fact that people from the diaspora do make contributions to international health and development. And we must not forget that aspect of our activities.
Okay, I think I saw Jamesia, then I saw a hand back there, and a hand back there, and a hand back here. So, Jamesia first.
Thank you. Jamesia Hoyle,
professor at George Mason University. Dr. Ngwa, thank you for the update, especially on the margins of the conference that we had at Harvard and just really understanding the growing threat of non-communicable diseases. It's very interesting to hear of your new partnership and looking to bring telemedicine, a stronger link with the diaspora, especially knowing that the ambassador is really looking to link this as one of her primary initiatives here at the AU. And so with that being said, I would wonder if you could provide an update on any partnerships that you have looking at research with minority-serving institutions here in the U.S. and also research institutions that are based in Africa.
Yeah, so that's actually a very good question. I think one of the things we've been doing so far in terms of research, at the summit we brought a number of African researchers who came and presented their projects. You know, to Alan's point about making it, locally relevant, you want to really make sure that you're not just coming up with a research project from here and then coming to Africa and say, okay, you're going to do it. But actually letting the people come up with their own areas where they really need to do research. Look, Africans are smart, right? They can develop low-cost technologies. They have a lot of potential. Actually, one of the things I've been saying is that when we talk about global health, we say it as if it's only the US who comes to Africa and helps the poor people. But we have to view it increasingly as Africans have a big contribution to global health, things that they can come up with that can help the United States as well. Okay, I'll give you an example. Actually, very recently, talking about research and biodiversity, we found a plant, an African plant, that actually produces hemoglobin. Okay, this is an ongoing research project, and it's something that can save a lot of lives in the United States. If you may not, malaria was actually discovered like that, right? I mean, the cure for Nivaquine. In African, a tree, the back of the tree, you can look at that and actually see that it can develop medicines from those. Through some of these research projects, I say that example to say that through some of these research projects, guess what? You can actually save lives here in the United States. And Africa has a lot of resources, the human and biodiversity and all of that. And I think that we want to actually change that conversation so that global health is viewed as a win-win. Okay? It's not just, the low-income countries that benefit. So we've seeded 5 collaborations that are actually ongoing now in research that are locally relevant. And mainly right now it's kind of limited to, having, collaborations with Harvard. These researchers can publish together, they can come up with, find new funding to go on with that. So that's actually one of the outcomes, and we're definitely looking forward to collaborating with CFA. You talking about, some of these funding, really great funding opportunities that, can engage more of minority populations as well. We know that the big issue here is also the mentorship, being able to find examples of minorities who can also participate, not just let other people do the research for us. So that's something that we actually look forward to collaborating with CFA on as well.
Okay, great. I'm going to answer just these final ones, and then we're going to have to move to the next panel. There was a question way back. Hello? Yes. Did you have a question? No? You don't? It's been answered? Okay, yes. You do have another question? Okay. Can you use a microphone and identify yourself, please?
Sorry. Good morning. Kevin Walter Smith, Omega Consulting Solutions. I'm a biomedical engineer with a background in defense and specifically chemical and biological threats. To the first statement that you had about FEMA, is there anything, Madam Ambassador or Mr. Foote, that CFA can do to write a letter or in conjunction with the folks in the Virgin Islands and the Caribbean to write letters of support or a strong recommendation, Mr. Dr. Herman, that you were talking about as well, to ensure that the infrastructure that FEMA is going to fund, FEMA and USAID and other defense agencies are going to fund to rebuild in the Virgin Islands, is there some way that we can ensure that African diasporans or African businessmen and women that have the resources and knowledge are put on some form of a preferred vendor list to be the ones that actually go in and do the work of the infrastructure. Because one thing we have a problem with in America is we have great ideals, but we mess up the end game, right? So the great ideal is we'll go in and we want to help, we want to fix. But the problem is that if you don't have folks that are representative of the diaspora that is needing the intrinsic help, they don't leave behind training, they don't leave behind infrastructure, they don't leave behind knowledge, they don't leave behind actual next generation that can actually do the work and implement it. And you can't inspire the folks of that community to do more of that work if they don't see fellow diasporans who own the industry and have the know-how like many of us in this room do, are the ones that are on contract to do that work. Is there some type of way that the CFA and the AU can get with the USVI leaders and somehow come up with a list of preferred vendors? Because what I will tell you from my experience in the defense contracting world, such lists do exist, especially on high dollar efforts of infrastructure and building. What many of you do not know is that there's already been a $1 billion sole source given by FEMA to a construction company out of Texas. It wasn't announced, wasn't spoken about, but a company now has $1 billion to go back and do the rebuilding and reconstruction of the Gulf of Mexico, uncompeted. And they do not look like anybody in this room. So the second question to Dr. I don't want to say your name wrong. Right, at Harvard, about working. Yeah, this doctor, yes, sir. I'm interested in speaking with you in terms of HBCUs, especially dealing with health disparities. Does Harvard have a mission space, or are they in tune with wanting to work with MSIs and HBCUs to specifically attack health disparities? Because there's an untapped budget of at least over $100 million a year that's specifically set aside by NIH and health disparities that our diasporans are not going after or competing for. And with the technical assistance and type of mentorship, I believe that kind of collaboration would accelerate the work that's being done at the Howards and the Charles Drews and the Morehouses. Because the other part to this is that if our diasporans are not in the game of precision medicine or this health infrastructure and science, we will not own our own genetic code in the next 5 to 10 years. We will not own the cures that we need that are intrinsic to our people. So is there some type of impetus or some type of synergy we can discuss, maybe not here but offline, about how we make that actually happen?
Thank you. For the sake of time, I want everyone to hold on to their answers to those very good questions. I want to take the last 2 questions and then have everyone respond at once. In the back first.
Hello, everybody. My name is Stella Damu, and I'm with the Pacha Foundation. And just 2 points. Her question about the AU's involvement or diaspora involvement with the crisis in the Caribbean. I'm hoping that Madam Ambassador can address that some more moving forward about how we can mobilize as a community to address those types of issues. And secondly, about holding African leaders accountable. You had mentioned about the self-evaluation process that is in place. What is the next step? Because we're finding out that going back to Africa, things are not changing for the better. Year after year after year, we're dealing with leaders who have shown that there is very little will in doing good for their people. How is the AU going to hold them accountable moving forward?
Great. I think we had somebody up here have a question.
I think it'll be a quick one, but Sterling Gornell, digital health strategist at ICF. So my question was for Dr. Wilfred. So a lot of my work that I do is, being able to develop behavior change models and using technology to address that. I know that, there may be some limitations from a technology perspective in some of these emerging countries, but other places like Nigeria, they do have the infrastructure to kind of use social media or use text messages and things of that sort. We actually have a program in Kenya, and we address maternal health with Mama to increase the knowledge and awareness of child maternal health for those folks in that country. So my question is a twofold question. So the first one is, can you just expand more about the demographic in terms of the folks who are more inclined to be more to have diabetes, alcohol consumption, and heart disease that you outlined in your presentation? And my second question to that is in terms of the digital solutions that we can implement. Can you talk about any type of infrastructure that can be improved to make it more streamlined for all the countries? Thank you.
Great. We have one more question. And anyone else with a question, we're going to have another Q&A after the next session. So please hold on to your questions. One final question, please. Yes. And identify yourself, please.
Yeah, I'm Joe Elias, and I work in the ICT space, and I have been with the Oracle Corporation up until a couple of weeks ago for the last 22 years. I'm also doing my research at Georgetown University and also the University of London on transformational leadership in Africa. And I spent a number of those years in the cloud computing space in particular, building supply chain models to consolidate purchasing at hospitals. My question, do we know of any programs that are regional, country, or even continent-wide that is consolidating purchasing and supply chain using the latest ICT and cloud technologies? I'd like to see if there's some discussion on that. I'd be interested.
Great, thank you. So we're going to answer. I'm going to ask our speakers from the last panel to respond to the questions. I'll start with the ambassador, please.
Okay, let's see. There were a couple of questions. Oh, sorry. Couple of questions. I think the first one had to do with contracts with FEMA from my brother in the back there. Again, I don't want to sound like a broken record. We don't exist. One of the issues that I've been just kind of bouncing around, often wondered why we have non-African CEOs in Africa of Western companies doing business in Africa. You say you can walk to Coca-Cola and say, Coca-Cola, could we please make sure that you hire Diaspora when you have to send stuff to Africa? And they will say, oh, yeah, sure, Ambassador, give us the names. Give us the list. We'll gladly give them the application. But guess what? That's when the conversation ends, because I don't have the list. Are you with me? We have got to stand up and be counted. It is that simple. So one of the things that I have decided we have got to do out of this office is to create a diaspora registry, professional registry. We need to know who you are and where you are, where you live, and what do you do. If we can each make a commitment to put in $10 a month, when issues like this come up, we have the funds for that. So yes, my sister, you raised a very valid question. We can't continue to say, well, better late than never. Let's do it. Let's make a commitment. If we each give $10 to St. Thomas, my whole thing is we don't need anybody to help us because we are very capable of taking care of ourselves. That's all I'm saying. You mean to tell me we each can come up $10? There's 50 million diaspora. If we each give $10, can we not solve our problem? But we don't want to think like that. We're just still in the savior mentality. I need us to get out of that. Rather than looking to say who can help us, we should say, okay, what do we need to do? Isn't that what we need to do in the village? When there's a problem in the village, the villagers came together. They went to the village meeting place and we discussed the issues and we came up with solutions. We never looked out there. So why are we losing that? That which is uniquely African. Let's come back to the village. We have a problem. Let's define the problem. We had issues in Sierra Leone. What did we do about it? Nothing. Now we got issues in the islands. What are we doing about it? Nothing. But what do? Sit back and complain. Well, they should have done that, they should have done that, they should have done that. What have you done? And that's the mentality I'm asking for. To say, as black people, wake up. You're very capable of taking care of yourself. Look from within. Talk to that image in the mirror. So yes, my sister, I hope one of the outcomes after this is to say, what are we going to do about the Virgin Islands? Because children of the African village, we got a problem. Let's solve it. And the next question that you threw to me, there was one about the gang of dictators from my sister back there. I hear that often enough. I am not going to stand here and tell you that African leaders are perfect. Absolutely not. We can dissect the problems in Africa into the Horn of Africa, the Lake Chad Basin. We can talk about the Great Lakes region. The problems are different. Great Lakes region, we're looking at issues of democracy. Leaders who somehow think, I like the one for Gambia, who loses the elections and 2 days later he says, I changed my mind. I'm not going. You can only laugh at that. It's unbelievable that one could do that. But it is what it is. Like I talked about, like any family. Got a, menopausal aunt, you got a schizophrenic uncle, you got a drunken father. But you know what though? We look at it as a family. It is not easy bringing 55 sovereign nations together and getting them to speak with one voice. The African Union collectively, they are aware of that. Believe me, Peace and Security Department at the African Union, it is the busiest. 60% of the budget for the African Union goes to peace and security. That's how important the African Union realizes that we have got to have peace and security before any development can take place in any country. So believe me, my sister, we are aware of the drunken uncles in our midst, in our family. And believe me, the African Union, Commissioner Chebi, he is the Commissioner for Peace and Security. I feel sorry for his wife. The man is all over Africa trying to, and the issues of Africa, because the leaders are part of, they are members of the union, you have to be very careful how you deal with them. Because if you destabilize this situation, well, guess what? He also has 3 or 4 others who are his friends. So not only have you destabilized this, you have destabilized 5 more. So it's a situation that has to be managed very carefully, because at the end of the day, you want a consensus when they come to voting on issues. I'll give you a simple example. Right now, we're talking about continental free trade area. That's a big one, if we can push it through. That's a big one, if we can accomplish it. So while you're trying to handle this, you gotta make sure you need this vote, because we're trying to get rid of beyond AGOA. So it's not easy, because again, they'll tell you, these members don't have to belong. You can find a leader that if we push too hard, they'll just leave the union. And then you're really lost, because now you have completely no control over this leader. So it's a very steep mountain to climb, my sister. Believe me, but at the same time, I also want you to recognize those African leaders who are doing a heck of a job in their countries. We have countries that are doing very well. Sadly, we have some that are not. But African Union knows which ones, and they are working with them to try and get them to do the right thing. Unfortunately, it is what it is. But it is a problem that we are aware of. My brother, did I answer all your questions? Did I miss one? Or? Forget to? I think I did. Okay.
Thank you very much. Mel, did you want to also respond?
Yeah, first of all, it's great to be here. It's good for me to be here and be a listener and not a talker. But I heard somebody say something about Constituency for Africa and the effort to address the crisis in Virgin Islands in the Caribbean. The thing that strikes me, I'm always telling, my motto is don't agonize, organize. In fact, this week, Congresswoman Christensen and the ambassador of St. Kitts and Nevis invited me to lunch to talk about recovery from Irma and what's needed. And so we had a healthy discussion around strategies for the Caribbean and what they might do. They see what I try to do on Africa. There also need to be a force to do that on the Caribbean. There needs to be a catalyst out here to try to bring. But I'm looking at it and saying, boy, I'm swamped. I'm just absolutely swamped. Last month, Sierra Leone ambassador called me. They had the mudslide in Sierra Leone, and we got to save some lives and get some supplies. Then the Caribbean Irma hits, and I'm hearing these calls from the Caribbean. And then I'm hearing about DACA, and the African immigrants are fearful that they're going to get deported by Trump, and we got to do something about that. And I'm saying, where does it ever end? We're going to have this conversation on Thursday here at the AU mission in the very room around Diaspora efforts to unify and cooperate. We're not getting anywhere like this. I listened to Ambassador, when she first talked about this $10 business, I said, well, gee whiz, this sounds like some Reverend Ike stuff or something. It didn't make a whole lot of sense to me. But the more and more I listen to it, it makes a lot of sense. We got to start somewhere. We have got to put down a marker somewhere, and we have all got to be responsible. If not, we're going to be running from here to there, jumping from issue to issue. It's all compelling, it's all compelling. But I do know that the way we're going right now, as soon as some crisis come, here's the call, come to Mel, you got to solve the problem. And I'm not Superman. I'm not Nelson Mandela. I'm not none of that, But we're just trying to build a catalytic movement to be able to address some of these crises. So I'm just lending my support to the Ambassador Chihombori, what you're saying in terms of the strategy going forward. It's not perfect. We know we got problems. That's why we're here. If we had the solution, it was readily available, we wouldn't be here. We just open up the fridge and pull out the solution. But we're not. We're here because we have to actually organize ourselves to not only address the immediacy of the problem, but to put something in marker so that the children and the children's children going forward will be able to do something. So you get frustrated hearing this stuff, and every time you cut on the TV. But I am saying that we just got to move ourselves forward to get organized.
Let me just make one more comment, just to follow up on what Mel has just said. Along the same lines, again, I'm saying we are the African Union. We have so many diaspora who are ready, willing, and able to go run for offices in Africa. They can be parliamentarians all the way to heads of states. But we got to support them. So even out of that $10, if we say $1 is going to go towards campaign finance, we can begin to finance good people who are able, that we as diaspora vet. The plan is to divide the country into 10 regions. And we'll have the board at the headquarters, which is here in Washington, and each region will have a board, and then each region will have sub-regional boards. So whatever sub-region you belong to, if they vet you and feel you're good enough to run for office, then they endorse you. They send you to the region. The region vets you. If they think you're good enough, they take you to the headquarters. We simply endorse, because once this region and sub-regions vet you and they think you're qualified and you can represent the diaspora well, then go for it. That's how we can begin to bring change. Because if we think we're just going to sit here and expect the people in Africa to change on their own, it's not going to happen. Make yourself relevant. Let's support diaspora who are ready. I think yesterday we had one of us who ran for parliamentarian, the guy from Detroit. He was sitting over here. He didn't make it because you know what? He was funding himself. It's all about money. You're coming from here. You don't have the infrastructure on the ground. You are starting from way behind, so good talent stays in the diaspora without getting into Africa and bringing the needed change. So also, let's put our money where our mouth is. $1 goes towards campaign finance. Those individuals who we vet, that's how we begin to make a difference. That's my 2 cents worth.
Great, thank you. Okay, so we're going to have responses to the other questions. I'd like to ask the responses to be brief. I don't think we have all of our speakers for the afternoon, so we're not as rushed as I thought we were. But anyway, please give your responses to the comment.
All right. So I think I had 2 questions, and one for my brother behind there. The question on HBCUs and getting more involved. I should say that actually I took advantage of one of that kind of funding opportunities. Actually, I got $1 million from that kind of resource to support, to actually use for mentorship. And I think it's a really good suggestion. So to be brief, what I would say is that, I'm happy to talk to you offline after this, about ways that we can work together to get more people involved. Harvard does have some of those programs, but, they are not where we would like them to be, So I think, that's something that we can really enhance. To my sister's question about, how can you use IT, for these, in Africa, things like diabetes. As far as I'm aware, we have many such. I should point out that Africa, 93%, right? People have mobile phones, cell phones. People may not have toilets, but they have mobile phones, right? And so, we are connected. We've actually leapfrog technologies. We've jumped over landlines. Some people didn't have to deal with landlines. They're actually having mobile phones. So what we are increasingly seeing is that you can use those to reach people in the villages. And we have very good programs on that for cancer prevention. And I think that, looking at diabetes and all those other things would be a really good thing to do. Mental health, I know Dr. Sam behind there is very passionate about that. But, increasingly we actually have, talking about resources, we have a lot of those resources being available. We only need to organize. We only need to organize ourselves, to actually take advantage of those. So I think that that's something that, we definitely want to also move in that direction. My last remark is about concerning the gentleman behind there who talked about the supply chain and using ICTs. I think that's a really good thing. As I mentioned before, ICT is the future. I think that if we're talking about any strategy for turning brain drain around, ICTs have to be part of it, because that's really, whether it's online learning that you talked about during your first, you've been advocating for that, or telemedicine, which Jerry talked about, or, organizing each other, using that for advocacy and all of that. Cancer prevention awareness, like Harriet does with her blog, that has to be at the center of any strategy to turn brain drain. And I would say, we have to stop talking about it, because if you actually bring Africans connected using ICTs, then you don't have to talk about geographic barriers. The brain drain idea that, I'm here, I cannot help, doesn't really work anymore, right? And that has to also go to industry, supply chains, all of those things. I mean, that's what eBay did, right? With industry, people can connect everywhere. So I know that works very well now in agriculture in Africa. I know in Zimbabwe, there's a very good model for that, but I'm not sure about healthcare. But if we don't have it, I think it's something that you need to do, because somebody is going to do it. It's the future. That's what I would say.
Thank you. Were there any other responses?
Just one closing response, I guess. The fellow in the back talked about the HBCUs. Former Surgeon General Jocelyn Elders, she would always say, you cannot be what you do not see. So the issue is more people being upfront. Just like here, we're going to have recording of this particular session. The issue is how are we going to disseminate that so people will see that something is happening, something is going on. We have engineers in here. I don't think the first time we had the session 3 years ago, we didn't have engineers. We didn't have people from the computer industry. So the word is getting out there. All this stuff is a part of it. And as my opening statement was concerning, what is healthcare? It is not necessarily a hospital. It's not necessarily a physician. It's not necessarily a treatment. So all these things come into improving the healthcare infrastructure. I talked about water, sewage, agricultural interests, feeding people, those things. I think that all these things need to be gotten out to the populace as to what is going on here. Thank you.
We're going to have a presentation by Mr. Raymond Dabney, who is the president, CEO, and co-founder and director of Cannabis Science Incorporated, a U.S. company specializing in the development of cannabinoid-based medicines. The company works with leading experts in drug development, medicinal characterization, and clinical research to develop, produce, and commercialize novel therapeutic approaches for the treatment of illness caused by infections as well as for age-related illness. Its initial focus is on cancers, HIV/AIDS, chronic obstructive pulmonary disease, asthma, and neurological conditions.
Wow, what a session. Yesterday's session was very dynamic, and today's session is, I have to say, just as dynamic. I came out here, probably the first time was 3 years ago. One of my directors on a board of our scientific advisory board, Dr. Roscoe Moore, I have to thank you for introducing me to Mel and the team. They brought me on board as the chairman or vice chairman of the African Healthcare Infrastructure Committee. They brought me on board as one of the directors of the of the constituency for Africa. What we're doing here is truly profound, and it is fulfilling spiritually, and financially. And most of us are all making history, and we're changing lives for the better. And I want to thank Your Excellency, Ambassador Chihombori. She may have taken off. She's really opened my eyes in these last two sessions, especially this year. The first years that I came here, we have a lot of ideas and a lot of things that we want to accomplish. I am certainly an entrepreneur. We own a bunch of different companies and a whole bunch of different industries. At the end of the day, we're here to, make a change. And, my name is Raymond Dabney. I am a member of the Diaspora. I'm not a doctor. I'm an entrepreneur in the true sense of the word. My DNA is to make things happen and make new things happen and to make old things happen better. And, this change that we're talking about in Africa, the decolonization and all these things going on, is really amazing how the things that we're doing here are not reflected over there, because we're all successful as compared to what's going on in Africa. And I'm certainly an advocate for change, and to me that's the main component of any type of success. And nothing is ever perfect, and when you venture out to succeed, or at least you truly try, you'll actually be surprised what you can accomplish. And when you do that, it really doesn't matter what anybody else says about you or your ideas. You just have to go for it. And that's what I do. I venture out into brand new, groundbreaking territories. Mel invited me to join the CFA 3 years ago. I've become great friends with everybody that we're working with. Roscoe, Will, Dr. Herman, Dr. Garvey, Ron Dellums, and the list goes on. And I consider them my great friends, and definitely consider my mentors, and I've really learned a lot. Mel brought me on board to do one thing, in my opinion, and that one thing is to make things happen, and that is what I do. And I have to thank Will so much. I wanted to tell the story a little later, but Will beat me to the punch. And it's amazing, because I was invited to a dinner from our good friend Sam, who is the president and founder of the Association of Psychiatrists of America. And his association is about 1,000 psychiatrists across America, and we were discussing PTSD. And when I walked in, Harriet was there. She's not here now, but with one of her friends, and she was literally bouncing. And she was bouncing because she was telling Will my life story. And she said, "Ray, you have to tell him your life story. You have to tell him your life story." So I did that, and I began telling Will about my ups and downs, the sideways, everything that we've been through. And at the end of that conversation, you know, I said to myself, man, I would love to work with this kind of a person, because he's a doctor, he's a scholar, he's an extremely intelligent man. And if we could do something together, that would just be phenomenal. And Will turned around to me and said, I would love to work with you, because two people from two different worlds of academics and entrepreneurial, if we can bring that together, we would really be building something profound. And that is exactly what we did, is we've built something very profound. After I finished highlighting everything, we've really accomplished something major with our relationship. We signed an agreement approximately 3 weeks to a month later with Dana-Farber, and we actually have our first work published in the Frontiers Journal of Frontiers of Oncology. Yes, and again, I'm not a doctor. I'm an entrepreneur. I put together deals. I structure companies in all different sorts of industries, and you know, we actually have two collaborative research agreements with Dana-Farber Cancer Institute. They're centered on cannabinoid drug development. We're together designing new treatments using cannabinoids, and you know, it's amazing that the actual work got published today. So everybody can go out and read it and see the results of our initial studies. And that is the whole point, is we had to begin somewhere. So the biggest problem out there was the cancer that we're targeting. We actually expect to have an FDA drug approved, and as a result, we're looking to bring these ideas and these technologies and these processes to Africa. And it certainly proves that our innovative thoughts are real, and as an extension of the project, we're working together with African governments and private institutions and individuals to bring it all together and expand our research footprint across the continent of Africa. Our new focus is on university education and community enrichment programs and entrepreneurial job creation initiatives. And these are all things that I've been hearing about in the last 2 days about what's needed in Africa. And to be able to provide that and be a part of it and help with this complete economic development is just mind-blowing. It's amazing. And I'm all over the map with my speech because my eyes got open today. I had a completely different speech laid out, but because of what's going on, and I see the change in the crowd. I think Roscoe mentioned it earlier, that the crowd has changed. The diaspora has changed. We're getting technicians, we're getting a lot, let's say, a greater diversity of intelligence is what I'm seeing, and it's great. And you know, at the end of the day, as a part of our educational economic development programs, we actually have 3 different universities now. One of the universities was created from scratch. It's called Raymond C. Dabney University, and we specialize in entrepreneurial job creation programs. And we also specialize in traditional job creation and dealing with law, business, and medical degrees. On my first trip to Africa last year, we actually signed a partnership with the International University of Management in Namibia, and that was to bring our entrepreneurship programs and to start up an exchange student program, because they were very interested in bringing their students over to the U.S. so they could experience the American lifestyle, while the Americans would go over to Namibia to study over there. The second university I purchased about 3 years ago, and it's called American States University. It has about 37 trade courses in 5 different departments. We have a Department of Agriculture, we have a Department of Business, a Department of Arts, a Department of Technology, a Department for Certified Professionals. We are aggressively going after programs to educate people so that when they do graduate, they're not actually going to look for a job, they're actually going to be creating jobs in their community. So one of the examples that we have is our first project with American States in our agriculture department is with a Native American group out of Northern California. Essentially, we are integrating our Department of Agriculture into their farming community. They own several thousand acres of land in California. We began the program by growing hemp for research and educational programs, okay, and job creation in the surrounding areas and for their actual tribal members. Okay. We've already hired approximately 50 people to work on the projects. We've planted the hemp, and right now we're actually cultivating. We're actually harvesting, sorry. We only planted about 60 acres out of the 250 acres that we signed a contract for. And the reason why was because it was late in the year and we wanted to get the job done so that we could actually get through a season and go through the curriculum. Now we're harvesting, and we expect to hire another 50 to 75 people, approximately. This model is exactly what I spoke about at last year's conference. And while we're on our journey through Africa, the education and job creation through the agriculture research is very specific to what's going on and what's being talked about in these sessions. It's all outstanding opportunities for large-scale land owners. And of course, in Africa, there's nothing but land. Some of our areas of research are cancer for alternative medicines program. We have cancer research, PTSD, chronic pain, arthritis, epilepsy, autism, HIV/AIDS, Parkinson's disease, and the list goes on. And each one of these areas, we need doctors, we need specialists to work with us to help train these students that want to actually create a career in any one of these different specific industries. Some of the other ones that we're developing is alternative fuels using hemp, construction materials using hemp, clothing materials, auto parts, rope, strings. The list literally goes on for the many uses of hemp. As far as cannabis is concerned, it's a much different animal as compared to hemp, because cannabis is known to have one of the cannabinoids called THC, which is psychoactive. Hemp has a much lower level of psychoactive THC, so the government seems to want to be a little more lenient on hemp, we'll call it. The curricula covers as well regulatory compliance, company creation, company structures, department management teams, operating staffs, planting to harvest, laboratory testing, formula creations, manufacturing, distribution, observational studies, clinical studies, and sales and marketing. And this is the full circle of operations that's required when you get into any industry, not just the medical industry. And again, 3 years ago, we talked about what we wanted to do, and today we're actually doing it. And these areas of job creation throughout that we have an opportunity to partner and work with the African Union to actually take it right across Africa is the word that I learned from Dr. Julius Garvey. Marcus Garvey is his dad, and he's known as a Pan-Africanist. And I'll have to tell you, I am certainly a Pan-Africanist. And I think everybody in this room has the same mindset. It's only a matter of, can we do it? What can we do? How do you make a difference? How? And a lot of people don't even start because they see that it's too big of an issue. They think that their one little idea is not going to make a difference. Well, we are certainly here to help and work with everybody to actually conglomerate all of our ideas and thoughts to work in these different areas to help Africa grow back to what it should be. Since Since I first came into the CFA, I worked closely with Mel and Roscoe to enlarge the value that CFA can bring to the continent. But we still have a long ways to go and many more exciting things to do. I'm excited and I'm committed to this journey for sure. On my first trip to Africa, we put together a delegation. Dr. Herman, Dr. Garvey, Mel, and Roscoe unfortunately couldn't go, but we missed you, and Jacques, of course. And, I really have to thank Jacques. This man is behind the scenes. Not a lot of people hear about him, but I'm going to tell you this much. If it wasn't for Jacques and it wasn't for Harriet, and I got to thank you too, we all would not be as organized as we are. So just please, thank you. So when we went, we stopped in Cape Town first, and I was definitely, I was floored because it was the motherland. I got there and I just had a feeling come over me, like, wow, this is home, and it was eye-opening for me. 100%. And after that, we went to Robben Island, where Mandela was imprisoned for 27 years. Then we went to Johannesburg, and and then we went to Namibia. And throughout this trip, we spoke with different ministers of government in Ministry of Health, Ministry of Finance, Ministry of Social Services, and the list goes on and on and on. And at the end of the day, we're now negotiating for several different partnerships, collaborations with university, government programs, all of these things that we're talking about now. And, at the end of the day, we need help. That's what's going on. And I'm probably like this because I know you guys work a lot, but, I'm not sure how I do what I do. But I know I do it because I have great people working with me. And I just want to thank Fabiana, Mitzi, and recently my daughter. She's joined the team. So, it's all about bringing everybody together, and that is really what we want to make happen. And now that Mel has introduced me to a person that I'm becoming very good friends with, the Ambassador Chihombori, it looks like we're going to be working very closely with the African Union, using our resources and their resources together to be able to expand our initiatives and all of our opportunities across the continent, and partnership with all the different countries and find out what they need, walk in there, do our assessments with them. The best part is we don't even really have to assess it. Everybody already kind of knows what they need. All they need is that opportunity to apply the answers to their situation. So we invite those that have an interest to talk to us about what we're doing, become a part of what we're doing, part of our team. You can talk with me or you can talk with some of our staff. Thank you very much.
Thank you for that presentation, Raymond. We're going to have some final words for the panel. Basuma Muhammad, you heard from her in our a little earlier asking some questions about Sudan. She's now professor at Purdue University. So you want to say a few words, please?
So I'll talk to you about Aortic. Aortic is an African organization for cancer, for research and cancer, and training and cancer. Let me say it from the beginning. African Organization for Research and Training in Cancer, which for short we call it Aortic. It's like the Aortic. So the organization mission is to raise cancer awareness and to help in building infrastructure in Africa. I had the honor, the organization actually started in the 80s. But because of the communication, and at that time there is no Google and the easy phones used, so kind of went dormant for a while. In 2000, at the meeting of the American Association for Cancer Research, few of us African in the diaspora met, and we decided to reactivate the organization. And so from that time, we spent from 2000 to 2003 looking at the logistic of how we're going to form the organization. And although we developed a team in United States, and we called it aortic in United States or North America, but our goal is to take it back to Africa. So we took it for our first meeting in 2003 in Ghana, Accra, and we started the organization there, and then we chose a president and vice presidents for the organization. And from that time, we start having our meeting every other year. So we were in Cairo, we were in Dar es Salaam, we were in Cape Town, we were in Durban. And last year we were on Marrakesh, and this year we are going to be in Kigali, Rwanda. So the organization is governed by a president, a secretary treasurer, and we have a vice president for every region of Africa, like due to the classification or division dividing the African continent according to the WHO into 5 regions: North Africa, West, East, South, and Central Africa. So we have a vice president that deals with the issue for every country. We are just having our nomination, and if you will love, but you can vote actually. But right now we are in the process of choosing, we choose those vice president and the president every 2 years. And now the voting actually is going to open tomorrow for voting for these people. So the organization started very small, but now we're almost getting to 1,000 attending the conference. So it's becoming really very big, and we're getting interest of most USA organization to be interested in. So that is about African Organization for Research and Training in Cancer. I want to tell you a little bit about my work and what I did to help Africa. When my husband and we came to United States, we really thought we're just gonna be, the time was we're gonna do our PhDs and we're just gonna go back. We never thought we're gonna be staying here 40 years. We never thought that. If you tell me today, that's what we never thought. So like most of us who came here, we did not come by choice, and we forced to be here. And there is, I know Trump is talking about all these people come here to take America and stuff like that. There's a lot of things going in our life he does not know about. Leaving your family there and establishing a new life here is not easy. And then when you can become older like us, you don't know whether you're gonna go back to most of your family who died already, or you're gonna stay with your kids who become already American and they don't know anything about your country. So it's really tough. But I decided to do something to help our people in Africa with cancer. So one of my projects there in Africa, especially in Sudan, we know here women are privileged by going to have mammography every year and to detect for cancer early so you can treat it. Because we know the earlier you detect cancer, curable will be. So I went into the rural area of Sudan, and I picked about a young girl from 29 villages, young girls that, between 20 to 25, and brought them to the cancer center. And I taught them how to do, actually me and my colleague there in Sudan, how to detect for abnormalities in the breast. We train those girls for, that is just a very simple, because buying mammography is very expensive, and not that, as I heard somebody talking about, there is other technology or things, like technician who take care of the mammography itself. We lack all these skills in Africa. So, but using this simple method of looking at abnormalities in the breast, and then just having, we don't need to look at the stuff that we don't see. At least let us look at the stuff we can see. So we train those, and then we send them back into the village, because those women, like, a woman from your own village, you are more relaxed with her. You can, you can be open, and you can see, help women examine their breast. Then, because most of these women are kind of coming to the hospital and looking at all these machines, or even, they're very intimidated by the situation there. But having these women going back to them and screen them for breast cancer, that was, our goal. So our experiment was really very successful, and we were able to screen 7,000 women on those 29 villages. And we found most of the abnormality we found mastitis, inflammation of the breast. And we found very few women who has early lesion of cancer, and we were able to cure them. And that was something that I really and I'm happy about. And now we have still the study is going to look at that, because we have done control villages and experimental villages. So now we're going to look at the control villages to see, whether we're going to see the same. So that is one of the things that I'm doing. The second thing I'm doing is that we know that also women here, privilege again, they go to cervical cancer screening, and they get tested for every year. They go test them for HPV or looking for abnormality of the cervix. And so I collaborated with a friend of mine at Purdue University to try to find a device like a pregnancy test. Because in Africa now, women, they don't get screened for cervical cancer. If they come one time and they found they have lesion, they take sample from them. They told them to come back, they don't come back. We don't have enough pathologists to look at the samples that is being taken. And so I thought about something that the doctor can do immediately, and they can treat them, because if they let them go, they're not going to come back. Everybody tells them cancer, they never come back. So we are in the process of developing a small device, just as I said, as a pregnancy test, and I have developed the markers in my lab, and hopefully this is will ban one day if we had enough funding to finish it. And I think Will is getting very interested on it one time, but I don't know now. So thank you, that's all I like to say.
Well, thank you for all the hard work you're doing on that. It's very, very important. Thank you for the two panelists for their contributions. Of course, we're over time, but if anyone has a burning question, happy to have you ask it. I see one burning question in the back.
Just a quick question about the device that you're in the process of developing for screening cervical cancer.
Mm-hmm.
How does that compare with what's currently being used? When we go on our medical missions, we do the VIA or VILI.
Yeah.
How does that compare with that as far as?
So VIA which is visual inspection. So you put some acids in this. Is mostly subjective, and it needs high trained personnel. So also HPV, we know that they're doing this HPV test. HPV test, a woman infected with HIV not necessarily is going to develop cervical cancer. So few of them, and then now we know there is many strains, and the test that is being right now, it might not have the same strains in Africa, and now they are making it double, triple, quadruple, so having all these tests for different viruses. And the gold standard is pap smear, but we don't have enough pathologists really to go around, plus the infrastructure for women to come back, because when they take a sample, it needs at least 1 week for it to be processed and read. So we don't have that infrastructure of recalling the women back. Yeah, but this test is hopefully it has to be, hopefully it will be very accurate. And you know, the same as pregnancy. Pregnancy test, when they started, it wasn't that great, but now, next day you can measure the thing and it's very accurate. So everything, people when develop it, it will work.
One burning question, last burning question. Okay.
Yeah. So, burning question to Raymond. So, burning question to Raymond. You are really an inspiration. I've actually been working with a lot of minorities in the United States, and I know that, your example is definitely an example that many of them, most minorities I talk to, they say, they don't really have good role models, right? So some tell me they have to make a choice to be in college and leave their friends, or, they can stay with their friends and stay out of college. And they only want to play football and all of those sort of things. And so, I've actually had that kind of situation. So I think your example is really an example that needs to be amplified, despite all your challenges, you're able to, be there. And I just want to, talk about Roscoe mentioned that, we should try to disseminate some of these things, let more people learn about what's going on here. That's the kind of example that I think many more people need to hear. I know there's a big need for mentorship. So in terms of your universities, here comes the question. You have, talked about 3 big universities that you're creating. Do you envision integrating these universities? And to the questions that you're asking me, how do you see how you can integrate more of, African Americans, the diaspora, and maybe, now you're interested in being a Pan-Africanist, how that goes back to Africa as well eventually.
Thanks. That's a very important factor to our program and our plans. There was another university we purchased recently, and it is the university that I contracted with initially for RCDU to be able to actually provide law degrees. And I said to my lawyer, I said, look, what if we're a success and they don't want to work with us anymore? We've just, brought him 1,000 students and he's making a ton of money and pulls the carpet out from underneath of us. So I said, we need to buy them. So we negotiated a very good deal and we purchased them. And that's a prime example of university integration right there. So that university is the backbone because it actually has the actual accreditation from the California Bar Association, period. The other university, and as well, RCDU specializes in kind of my brain, which is entrepreneurship. So our ideas are to teach people not to be afraid to get out there and get into business. This is the whole thing. In growing up, I don't know how many times I was told, you can't do this. What do you think you're doing? You don't have an education, da-da-da-da, and it goes on and on and on. If I had listened to any of them, I wouldn't be here today. And even though, I don't condemn any of them or such, I just use it as motivation. So the integration there comes into the entrepreneurial programs. And it's such an important thing because I see so many students graduate and they're looking for a job. They don't have a job. And it doesn't even make sense to me why universities today do not give them a platform to actually create their own jobs. And I'm not just saying creating their own job, I'm saying creating an actual company. So what we're going to do is we're going to actually teach them how to structure a company, how to create a board, how to hire the lawyers, how to hire the accountants, how to do the audit, how to do all these things that I do on an everyday basis. This is what I do anyways. So we're creating the curriculums to do just that. So there's another key integration there. And one of the biggest integrations that you talked about in terms of bringing it all back to Africa was when we went to Africa and we met with the University of, the International University of Management. And, Yes, they were introduced to us from people that we knew. That's how we got in the door in the first place. But the bottom line is the entrepreneurial program and the student exchange program were the two reasons why they really wanted to partner with us. And the law degrees also, because they wanted to offer law degrees to their students. But the entrepreneurial program was of particular interest because, again, you're looking at helping people in the community create jobs. So when we go in and we put together our agriculture program, which means we'll go in and we'll cut a deal for 100 acres worth of land, we'll look for buildings, and we'll actually build a university there. What I didn't tell you guys, is that the North American, the Native Americans that we did the deal with, we're gonna provide all their tribal members with a free education. They can pick any course that they want, and because they made the deal with us for their land, we're going to give all of their tribal members a free education. And on top of that comes the economic value, financial. Why are we doing this? In order to make a change, you have to have resources. In order to have true resources yourself, you got to have money. That's the bottom line. So we actually make deals where we split the profits. So we're not walking in, buying the land and say thank you very much, goodbye. We're splitting the profits with the landowners and the communities. So now we go in, structure the whole thing, put it together, teach the community and the individuals in the communities how to run the operations. We're going to build dormitories, strip malls, all the retail services required and such. Hire the community, train them in the university how to work in all these different establishments. If they go through the entrepreneurial program, we'll help them set up the companies to run those organizations, and the university will hold back 10% of it, whatever the case may be. Because, of course, we have to strengthen the universities to be able to continue doing this all through different African countries. So that's a little bit of integration there.
That sounds great. We're going to have to close it off. I know there's some other questions. If you wouldn't mind coming up and asking our panelists afterwards. Except, Mel, is there a logistical issue? Go ahead.
No, I want to say a couple things. One, again, my condolences, Congresswoman, for what's going on in the Virgin Islands right now, and I know your mind is in several places at the same time. So I just want to go on the record to say that. Secondly, Ambassador Arikana is still upstairs in her office, and she asked if some of us could come out, stop by before we leave. I think it'd be good go up there, see how she lives and where she operates from, but take a few pictures. So I'm hoping that you all can join me up on the second floor for a few minutes with the ambassador before she leave. And I just want to say that it's exhilarating working with Raymond Dabney. Exhilarating is a good way of putting it. He's not your traditional anything, entrepreneur, but I've never seen a person who is fearless and who is courageous in many respects, who's willing to think outside the box. Really think outside the box in terms of building this partnership. He's not afraid to talk to the Harvards of the world, and he's not afraid to talk to grassroots people, in that regard. But from the CFA standpoint, it's been 3 exhilarating years. We're looking forward to going out to Rwanda with Dr. Muhammad and the Aortic conference in November. And so I don't know if anybody else who might be interested in going out to Rwanda, this is a good time to go. Certainly we can help you to get the information and make the connections. So I just want to thank you all for an exciting panel, and it just seemed to me that the African Healthcare Infrastructure Committee is really putting roots on the ground. And we want to encourage those who might want to join this. What you're seeing is a flat organization. It's not hierarchical. Everybody's a king and a queen on this group. And so everybody has a contribution to make. So my young sister, I'm talking to you. Make sure you contact Harriet and make sure she has your contact information to get on the database and get onto the email list. Thank you very much.